Dr. Sai Suryatej from JSS Medical College. Kindly present your case. Sir, you can put
Good afternoon all, I am Dr. Surya from Department of Medicine JSS. I am here to present my topic, comparison of different blood pressure measurement techniques in patients with chronic kidney disease under the guidance of our esteemed professor Dr. Srinath KM. Coming to the background of this study, two big entities, hypertension and CKD, having their own plus and minuses, having increased risk for CVD, ESRD and mortality in CKD, and CKD itself is strongly association with CVD risk. But in real life, they both actually work together in causing very debilitating diseases and comorbidities to the patients. So the present study was done in JSS Hospital, Mysore. It's a cross-sectional comparative hospital-based observational study spanning over a time of 18 months, starting from 1st March 2021 to 31st August 2022. So coming to our inclusion criteria, patients in CKD stages 2, 3, 4 calculated estimated EGFR based on MDRD, and patients above 18 years of age. And patients with known confounding factors are excluded from the study, including CKD stages 1 and 5, patients suffering from atrial fibrillation who had their antihypertensive medication changed in the prior month of the study, and pregnant and lactating women. Before enrolling into the study, we have collected the preliminary data, past, present and the drug histories from the patients, and we have enrolled in their pre-tested proforma, following which we have clinically examined the patients and then recorded the blood pressure using diamond manual mercury sphygmomanometer, following which we have recorded their blood pressure in the Omron Elite HEM 7600T device. All patients had their ABPM measurements done 48 hours after this. We have explained the patients about how ABPM works, about the daily routine, and need not have any changes in their daily routine when compared to this ABPM device. Coming to the demographics, 60% of the people were males and 40% were females in our study. And most of the people were between the age of 41 to 70 years, accounting to around 86.6%. So coming to the duration of the CKD in our patients, around 40% of the patients in our study have an average duration of CKD for around 5 years. So this slide shows the incidence of uncontrolled hypertension and CKD. As the CKD stage progresses, the incidence of uncontrolled hypertension increases. As you can see, 6 people in stage 2, 17 in stage 3 and 8 in stage 4 having uncontrolled hypertension even taking their antihypertensive medications. So these are the comorbidities of the people in the study. Coronary artery disease 6.6%, diabetes alone 22.5%, diabetes and CAD 0.83%, hypertension alone 51.6%, intrinsic renal disorders 11.6% and rheumatoid arthritis 2.5%. These were the recordings we have got from MOBP, AOBP and ABPM monitoring, where the awake readings of ABPM have correlated with the AOBP recordings, taken 3 average readings with 3 minutes apart, around 130.45 and 130.11 correlating almost similarly, and the uniqueness of ABPM, where we have got 8 people with white coat hypertension and 5 masked hypertension, and we have identified 22 non-depots in the study. This table will again tell the importance of the same, having the p-values of 0.04 and 0.03 respectively for ABPM and MOBP. There is a significant difference between their readings. This graph will make it more simplified, where this is the ABPM SBP awake and orange is the AOBP SBP average. The DBP of ABPM is in gray and yellow is AOBP average 3 recordings. So coming to the discussion. So coming to the present risk factor of hypertension, it acts as a both chronic risk factor in advancing the vascular diseases and as an acute risk factor triggering an acute CV event resulting in death in most of the cases in CKD. So the present aim is 24-hour BP control with strict 24-hour BP control less than 125.75 mmHg and 10 to 20% of nighttime BP fall, controlling the circadian rhythm, and BP variability of morning BP surge less than top 10 percentile. This slide shows you how hypertension can cause the damage, affecting arterioles, small arterioles especially causing arteriosclerosis, altered endothelial permeability affecting the afferent arterioles, ultimately resulting in glomerulosclerosis and chronic kidney disease at the end, and tubulointerstitial fibrosis. Degenerative or inflammatory glomerular diseases on the other end will be causing compensatory glomerular capillary hypertension, resulting in mechanical stretching of mesangial cells, podocytes and endothelial cells, resulting in glomerulosclerosis again, and increased production of angiotensin II. This will show a better way. There is hyperfiltration of the glomerulus of the affected capillaries, where you can see there is hyperfiltration happening with an endothelial dysfunction and altered protein mechanisms there. This slide focuses especially on a single PCT cell where there is increased glomerular permeability to the proteins, resulting in excessive protein tubular reabsorption and resulting in corresponding protein activation of Frantes and apoptotic signals, causing lymphocyte macrophage infiltration, mesenchymal transmission, and ultimately resulting in interstitial fibrosis. There were few studies which are done from 2012 to 2022 having a similar report, telling that there is higher risk concerned with blood pressure control in CKD patients, especially in non-dipping pattern, and decline in EGFR in non-dippers, and 10% higher nocturnal dipping associated with decreased risk of CKD and lower annual rate of EGFR. Guidelines which change every year need not be taken into account all the time, and there should be a rationale in adding a drug to reduce the hypertension in the patients of CKD, where we are evolving to primarily targeting morning BP control, since we have guidelines in 2015, to nighttime BP control in 2020, and we are emerging where BP variability control should be done by 2030. There were few more studies of adjusting the antihypertensive medications in the bedtime to control this nighttime non-dipping. So we have concluded that the study identified 27.5 uncontrolled hypertensives among CKD, very high correlation between AOBP and morning time average recordings of ABPM, and white coat hypertension is lower with AOBP. And limitations were limited study samples, and current study criteria were quite stringent because the same patient need to undergo all the 3 BP recordings and could not include all stages of CKD. Multi-center trials can be done in the future, and meta-analysis of existing research could be done. These were my references, and these were few other articles. We hope to keep the equivalent of the tree, kidney, with its intricate branches of blood vessels free from the disease, and keep it grow for longer time. Thank you one and all for giving me this golden opportunity, and happy Independence Day in advance.
Yeah, it's already known that ambulatory BP monitoring is essential in all hypertensive patients, irrespective of the mean blood pressure.
Yes, ma'am.
What does your study add to that statement?
We have emphasized not regarding ABPM actually, ma'am. We wanted to emphasize the importance of automated office blood pressure recordings, because we know classically only sphygmomanometer or the gold standard ABPM, but AOBP importance is not talked of much. So we wanted to, just in resource poor settings, rather than relying on mercury sphygmomanometers, better go with AOBP recordings that could identify a better morbidities and make the patient's life a bit better.
While recording manually, who recorded manually blood pressures?
I myself.
You yourself, for all the patients you have done?
Yes, sir.
Okay, good.
Because that's the time of COVID where we have limited OP also. We have time to spend, sir.
Because when you are comparing those things, that is also very, very important.
Yes, sir.
Same person whether he recorded.
Yes, sir.
What are the similar studies across the globe? What is the recommendation either by the Hypertensive Society of India or International or European Society of Hypertension regarding this?
According to AHA and according to ISH 2020, they have more emphasized on home blood pressure monitoring also, apart from hospital-based management or OP-based management, sir. So now they are also coming with newer set targets for automated office or automated apparatus used for home blood pressure monitoring.
Regarding that only, regarding that, what is your objective? Regarding that, what is their, this one, any positional statement or anything which is shown that it is superior to this?
There were studies, sir, which were done in done by Xiaomi et al. And China in 2015, sir. They have also done a similar study on 342 subjects, comparing the importance of AOBP, and they have given the same conclusion that average AOBP recordings taken at least some 3 times with 1 minute apart will yield a better result in blood pressure management rather than single mercury manometer or mercury sphygmomanometer recordings, sir.
Thank you.
Thank you, sir.